We're back with our second episode on Chronic Spontaneous Urticaria, also known as CSU. We're going to dive into how CSU is diagnosed. If you missed our first episode, we talked about hives and chronic spontaneous urticaria, just setting the foundation of what CSU is. So check that out if you're looking for a little bit more on just the basics of CSU, or check it out afterwards after you've listened to this episode because you want to know more. So before we get into the nitty-gritty of diagnosis, I was curious, Dr. Chi. Since CSU really involves the skin, who is the best person to see if you think you have chronic spontaneous urticaria? Are we thinking family doctor? Are we thinking allergist? Are we thinking dermatologist? Who do I go see?
So oftentimes, depending on the severity of the hives, a patient might be seen in an urgent care or emergency room for their hives because they think they're having an allergic reaction. So hives and swelling are just two of the many symptoms that can occur during an actual allergic reaction. So other symptoms, as we've discussed so many times in other episodes, include things like shortness of breath, wheezing, coughing, vomiting, diarrhea. There's so many different symptoms that occur during a true anaphylactic allergic reaction. But because hives and swelling or angioedema are also a part of those symptoms, a lot of people will think that they're having an allergic reaction, and so they'll end up in the emergency room or urgent care. And again, with CSU or chronic spontaneous urticaria, you should only have the hives and sometimes swelling or angioedema. So when they end up in the emergency room or the urgent care, they can get referred to a specialist like an allergist or a dermatologist. But this is a condition that can also be managed by a primary care doctor if they are familiar with chronic spontaneous urticaria. But the problem, as we've discussed in the last episodes, is that hives are common in allergic reactions. And so doctors and patients want to know what the allergen is. And that is where an allergist comes in and why we tend to see a lot of these patients.
You know, I didn't even think of urgent care as the first place someone might go with hives, but I actually recently this year had a reaction where I was literally covered head to toe in hives, and I also had some pretty extreme angioedema swelling, and that's where I went. That's where I ended up. I went right to urgent care because I had no idea what it was. I knew it wasn't an anaphylactic reaction because I've had those in the past, but yeah, I was so concerned that that's where we ended up, and afterwards they sent me to a dermatologist for follow-up, and I did actually multiple follow-ups with the dermatologist because of the direction that those hives went. Yeah, I can see that's why a patient would go to urgent care because I did that myself. So you mentioned allergists and dermatologists. Like I said, I was recommended to go to the dermatologist. They're at the forefront. So what are the roles of an allergist and a dermatologist in chronic spontaneous urticaria? How do they differ?
Yeah, so both allergists and dermatologists see patients with urticaria or hives. So really either is fine, but it often depends on the individual patient's symptoms and their medical history. So if the CSU symptoms are accompanied by other allergic conditions or there's suspicion of an allergen-related trigger, then an allergist may be the preferred choice. Like I said, an allergist is consulted in these situations often because oftentimes even the dermatologist is wondering, is an allergy causing these hives? And so we are the ones that test for allergies. And so we end up seeing a lot of these patients. Dermatologists also see urticaria because they are specialists that focus on the skin. So anything that's related to the skin, any kind of rashes are usually referred to derm, as in your case. The reason that I love being an allergist so much is really because we see conditions that affect the entire body and multiple organ systems. And so we actually share a lot of conditions with many specialists. Like, for example, we share asthma with pulmonologists or lung doctors, and we share EOE or eosinophilic esophagitis with gastroenterologists or stomach specialists. And so we share a lot of conditions with a lot of different specialists, and that happens a lot in medicine. And this is just one of those areas where that's also happening.
I don't know if patients necessarily know that allergists have so much crossover with other specialties, and I think that's really cool. But if I was someone, say, experiencing hives, and I don't really know that the allergist is the right person to go to, but I know it's my skin, but maybe I'm thinking there's food involved, I'm not sure. How do I decide between an allergist or a dermatologist?
Yeah, so I would encourage everyone to start with their primary care doctor or healthcare provider if the provider is familiar with the diagnosis of chronic spontaneous urticaria. Then they will start the appropriate treatment and the person will get better and their symptoms will be controlled. And then you may never need to see a specialist. But if the provider is not familiar with chronic spontaneous urticaria, the patient may not get the control that we want them to have or that they want to have. And so at that point, that's when a specialist should be consulted if the condition is not improving or if the patient is avoiding a lot of foods, for example, because they think that foods may be causing their hives. And in those situations, we really want them to be appropriately diagnosed. We don't want people to be avoiding foods that they're not truly allergic to, because as we've discussed again in other episodes, it really can cause a lot of anxiety for people, and eating should be as carefree as possible.
That's really true. And on top of food, I've also heard that people with CSU actually avoid certain situations because they're afraid. So going out on a sunny day or being too hot, I've heard people kind of closing their life down because of fear of things that could potentially make them break out into hives. Are there things that are impacting your daily life that you're avoiding because you're too afraid of hives? You think it's normal and you don't realize how not normal it is, and you forget what life can also offer. So going back to allergists and dermatologists, the last question I have is there ever a case where you would see both of them?
So yes, absolutely. When the diagnosis is not completely clear, sometimes in addition to allergy testing, which is where the allergist would be consulted, a patient may also need what's called a skin biopsy. And a skin biopsy is where we take a piece of the tissue and we're able to look at it under the microscope and see what the area that's affected, what those cells look like. And that really helps us diagnose what the underlying issue is or what the diagnosis is. And so if we need a biopsy, that's when a dermatologist would come into play because they're the ones that do the biopsies. Not a lot of allergists do skin biopsies, but there are some that may also do skin biopsies. So in those situations, both an allergist and a dermatologist may be seeing the same patient. And I think that once the diagnosis is clear, in my opinion, it's really best just to stick with one or the other, because having multiple appointments, having to navigate multiple doctors, maybe the doctor's not always being able to communicate and then giving the patient mixed messages, I think it makes things very confusing.
Yeah, and then you're shuffling paperwork from one doctor to the other and you're always comparing and contrasting. I can see that just being too much. If you feel like you've got your condition managed, just stick with one. That makes a lot of sense to me. Don't make it harder than it needs to be as a patient, right? So you mentioned a couple of things, and I think like skin biopsy, and I think that we should just jump into what this episode is about. It's about how do you diagnose CSU? Dr. G, how does it happen?
So it's important to remember that CSU is really an issue with the body producing hives on its own and not the external environment creating the hives. So what we do as doctors that is really important is to make sure that we ask all the questions that we need to ask to make sure that we aren't missing anything that could be causing these hives. So we need a very detailed history so that we can make sure that there isn't another underlying cause for the hives. So we need to make sure that we've asked about newly administered drugs, including antibiotics, something called non-steroidal anti-inflammatory drugs or NSAIDs, hormonal therapies, any recent travel, infections, changes in health status, any new diagnoses, any other allergic conditions, sexual history from the patient. So we do what's called a complete review of systems also, which means that we also go from head to toe and ask about the person's symptoms. So anything from weight loss to joint pains to cold or heat sensitivity, abdominal pain, bone pain. These are some of the things that we might ask about. Any kind of symptoms that have accompanied the hives or that are occurring around the hives. So anything that you're experiencing in your body, we want to know about that so that we can see, is there something else that could be causing your body to not feel comfortable, and any other symptoms that could help us understand what might be going on with your body.
Okay, so it sounds to me like you're really just looking for reasons why you might be experiencing hives, right? I know, just going back to what you said and about the experience I just talked about, my time at the urgent care, is they did exactly what you explained. They asked my whole history. They asked me about all these other parts of my body. And, I had joint pain, and I don't think I would have told them I had joint pain if they hadn't have asked, because everything was hurting and everything was feeling like weird and out of joint. But because they asked such pinpointed questions, I was able to say, oh yeah, you know what? Like, my joints are really sore and bizarre, and I've never felt that way. But I would never have thought to actually tell them that if they hadn't have asked. So I can see why you go from head to toe, because when you're experiencing something like hives, that's what you're experiencing, and you don't realize that there's other things going on in your body. So one other thing that they actually did at this urgent care appointment I had was they kept on pressing on all of my hives, and they kept on doing that in my follow-up appointments with the dermatologist. I'm curious, but why were they doing that?
Yeah, and I just want to quickly say that what it sounds like, Kortney, you were experiencing was definitely not chronic spontaneous urticaria. And it was a different diagnosis that involved hives. And so I just wanted to point that out, because you were having more of, I think we've discussed this, but you were having more of what was a drug reaction with the joint pains and the hives and the fever and all of these other symptoms. So that's a totally different diagnosis than CSU. But it's helpful because you were being evaluated for hives. So what was the doctor doing when they were pushing on the rash, and what were they checking for? So what the doctor is looking for is to see if the rash is what we call blanchable. And what we mean by that is blanch, as we know, means to turn something white, okay? And when we push on the skin in that area of the hive, what we're looking to see is, are we able to turn that hive white? And then when we take the pressure off, does it turn red again? And when it turns white, that means that we're stopping the blood flow to that area. And that means that the blood is still flowing in that area and it's still in the vessel, okay? And when we pull up on it, then we're allowing that blood to go back into the vessel. And when we press on it, we're stopping the blood flow. With other conditions, for example, like a bruise under the skin. Bruising is basically where the blood leaks out of the tube that it's meant to be in, or the blood vessel, and it's just sitting underneath the surface of the skin. And so when you have a bruise and you push on it, it's not going to turn white, because it's not just moving around the blood in that tube. And then there's also other conditions where the blood vessels are actually inflamed or swollen, and pushing on that area because those blood vessels are inflamed, and that's what's causing that redness and irritation. Pushing on those blood vessels won't lead to blanching, and the redness will just stay there even when you're pushing on it. And so that's an indication that it's a different condition, essentially.
Okay, so if you don't mind, I just want to quickly summarize blanchable. So what you're saying is that you can tell it's a hive as opposed to something else because it's blanchable. And what that means is that if I press on the hive or the rash and I release my finger, it goes paler and then it comes back and goes red. And that means that there's blood flow that's still happening. And when you press it, you're stopping the blood flow. When you release it, the blood flows back. So basically, hives should be blanchable. If it's not blanchable, it's not a hive.
Yep, that's exactly it. And in addition, the reason we were particular about saying that the lesions shouldn't last longer than 24 hours and shouldn't leave any residual marks is because if these things are happening, then we need to worry about inflammation of the small blood vessels under the skin, which again is called vasculitis, which is when someone has a condition that kind of looks like hives, but it's actually inflammation of the small blood vessels of the skin. And vasculitis can be a symptom of more serious conditions like autoimmune disease, drug reactions, infections, or malignancy. So if we are worried about vasculitis, we should send the patient for a skin biopsy to confirm that it is a vasculitis.
So that's one of the first steps of the elimination process of, is it a hive or not a hive? And if you have hive-like things on your skin, it's important to determine basically if it's a hive, because as you said, there's some other serious conditions that can masquerade. I've never heard of vasculitis, and it sounds very, very different from hives. So is that the only time that you would do a skin biopsy in this diagnosis process?
Well, really, any time that we're worried that the rash doesn't look like a classic hive, we would want to do a biopsy of the skin. As one of my favorite professors, who actually just recently passed away, Dr. Lambert, would have said in medical school, the tissue is the issue. We can find out a lot about someone's condition by looking under the microscope and doing a biopsy if there's a lot of confusion going on. And I just want to point out that doing a skin biopsy is not a required part of the diagnosis of chronic spontaneous urticaria. And in most conditions that cause urticaria, we don't need to do a biopsy of the skin to confirm it. It's really when the rash and the skin and the urticaria, or what we believe to be urticaria, are not behaving like normal urticaria.
At this point, you've confirmed that indeed it is a hive, and you've taken the medical history, so you've asked questions like, are you taking any recent medications? Have you been traveling so you can eliminate viruses that potentially could cause hives? And there's also patient history and other conditions that might also cause hives, because we just finished this massive series on mast cell disease, and I remember that one of those symptoms of mast cell disease was hives. Do you also investigate, is there anything else in your medical history or potential other medical conditions you could have that are related to hives?
Yeah, of course. And that's an important reminder that, yes, we did just do a series on mastocytosis, and that is where the mast cells are not working like they normally should, or there's more mast cells than there should be. And so they're releasing chemicals that are in mast cells. And one of those chemicals is histamine, which is why a primary symptom of mast cell disease is hives. And so mastocytosis is also something that we consider when somebody comes in with chronic hives. In addition, hives can also be one of the first things that someone comes in with when they're diagnosed with an autoimmune condition, or it can occur sporadically over time in patients with autoimmune conditions. So we don't know why this happens exactly, but it's important to make sure that the patient doesn't have other symptoms that might indicate one of these conditions. And that's why, again, we ask a patient about all of the symptoms that they might have been experiencing around the episode of hives to make sure that we don't miss another disorder that is present. Because the hives, as you mentioned, are so bothersome to people, sometimes that's the only thing that they're thinking about. Like when you were in the emergency room, if they're having other symptoms, they may not even put two and two together. And so that's what we're helping them do.
Yeah. Sometimes when you have hives, you just think of the hives, and there's like all this other stuff that's happening that you don't even have top of mind. I just want to remind everyone that Dr. G said histamine, and I know that like histamine is this thing that pops up all the time in our podcast. If you're new and it's the first time you're listening, check out the first episode we have about CSU, because we dive into histamine and its relationship with hives. So if you aren't sure what we're talking about, go there because it's a really good explanation. We also talked a little bit in the first episode about the autoimmune conditions associated with CSU. Can you just remind us a little bit more about what we're talking about when we talk about autoimmune conditions?
Yeah, so autoimmune disorders are diseases where your immune system is overactive. So your immune system is attacking and damaging your body's own tissues. So some of these diseases are found to be more prevalent in patients with chronic spontaneous urticaria, like thyroid disorders, celiac disease, Sjogren's disease, systemic lupus, rheumatoid arthritis, and type 1 diabetes. So what's interesting is that for patients with chronic spontaneous urticaria, an autoimmune disorder was more likely to be diagnosed in the decade after the onset of CSU rather than before it. So what that basically means is what I had mentioned earlier, that sometimes chronic spontaneous urticaria can be one of the first symptoms, technically, of that autoimmune condition that's starting to develop. So again, it's not that everybody that has CSU is going to have an autoimmune condition, but we do find that a lot of patients with autoimmune conditions have had chronic spontaneous urticaria during that process.
That's really interesting to hear that the autoimmune condition comes after CSU. I would almost think the other way around, but maybe that's something for people to remember, that if something is happening after your CSU diagnosis, that you could consider it autoimmune disorder. So back to the beginning of the journey, because that's where we are. We're diagnosing CSU. It sounds to me like it's basically a process of elimination at this point, but I wonder, are there any tests that you would do, Dr. G, other than the skin biopsy, which we talked about?
As far as tests are concerned, I just want to say that we limit the tests that we do in all patients because we don't want to over-test for anything. With other forms of urticaria, as we've discussed in the first episode, there's also something called inducible urticarias. And that's where we might use other tests like doing the cold or heat or UV or pressure test, where we apply pressure or we apply cold to the person's skin to see if they have an inducible form of urticaria. And for that testing, I just want to mention that you need to be off of oral antihistamines for at least 2 to 3 days. Otherwise, we won't be able to induce your hives because we're blocking the hives with that antihistamine. So again, we only do testing that makes sense for the patient's history. And sometimes we don't even need to do the inducible urticaria test because it's obvious that whenever they apply pressure, that's the only time that they get hives. Or whenever they're exposed to cold, that's the only time they get hives. And so there's no reason to re-expose them to cold in the office and have them hive. But if we need to just kind of clarify and make sure of the diagnosis, then we will do that testing.
We also mentioned at the top of the episode food allergies and people going to the ER because they think they're having like a food allergy reaction. Do you do food allergy testing at all in this process?
So this is actually a really important topic, and why I think it's really important to consult with a specialist if food allergies are being considered in the diagnosis. So food allergy tests should not be ordered unless they're absolutely necessary. And the reason for that is over-testing can lead to the misdiagnosis of food allergies. And many people will have what we call a false positive on testing. And so a false positive means that a test looks positive, but the person is not actually allergic to the food. And that can happen a lot with any type of testing. And so that's why we really have to limit the type of tests we do. And especially with foods, it'll lead people to avoid foods that they don't need to be avoiding. And again, restricted diets and anxiety around food can cause a lot of just general quality of life issues for people.
And when you talk about false positives, I can also imagine that if you have a really reactive skin already because you're getting lots of hives, you would probably want to avoid a skin prick test because of that.
Yeah, so you can do food allergy testing by either doing blood or skin tests. And sometimes we need to do both for a patient if we're worried about a food allergy. But you do bring up a really good point that for people with urticaria or hives, they oftentimes are very sensitive or have dermatographic skin, which means that you can literally almost draw on the person's skin. And so applying pressure will cause the mast cells to release the histamine. So that can happen for people with lots of different types of hives. They just tend to have more reactive skin. So this means that their skin tests will show more false positives, and blood testing can also result in false positives. And that's why I don't like the use of food allergy panels.
It sounds like there's a lot of times where a false positive can happen, and it's interesting to hear that you really are very conservative when you decide to test for food allergies. As someone with food allergies, I'm just curious, are false positives very common?
Yes, you need to always look at testing and history together to make a diagnosis of food allergy. I can't emphasize that as much as I want to because it's so important. If a person is able to eat the food without symptoms, then they are not allergic. So the reactions to a true food allergy should happen within 30 minutes, sometimes up to an hour. And it should really occur every time that that person is exposed to that food that they're allergic to. So we don't need to test everyone for food allergies, and we don't need to use panels. We only test for the food that we are worried about. And these tests, again, need to be looked at with the history in mind.
You mentioned food allergy panel. Can you clarify what that means?
Yes. So a lot of lab companies will have what they call a panel in their system. And that's where you can test for a lot of foods at once. You can just pick one code, and then that'll just give you a whole host of allergens. And sometimes that's just easier when someone's ordering blood tests. They don't want to click on each individual things, but these panels are dangerous because, again, it can lead to a lot of false positives if you're over testing. And I personally don't think that panels should exist in general, except for maybe things like a shellfish panel, because those allergens do actually come together. If someone's allergic to crab, then we want to know if they're also showing sensitization to lobster and shrimp, for example. But other than that, most panels are not appropriate. And again, a lot of doctors that are not allergists might rely on these panels just because it makes the ordering of the test easier. We also see this oftentimes with kids with eczema that also get over-tested for food allergies.
Actually, my best friend just got a food allergy panel, and she got a lot of things come back positive that she eats all the time. And that's exactly what I said to her, is I was like, I know that Dr. G always says that if you can eat it, then you're not allergic to it. So don't freak out. And I know that unless we had that discussion, I feel like maybe she would have started to eliminate these foods, even though she's like a totally smart woman. It's just that when you see a test that says it's positive, you instinctively want to freak out, right? So again, history is so important to take into consideration. So we talked about food allergies, but what about environmental allergies? Do you ever test for those?
Yeah, so environmental testing can be done if there are classic symptoms, again, accompanying the hives. So things like runny nose, congestion of the nose, itchy, watery eyes. If someone's worried about a new pet that they just got and they started having hives in relation to the pet. And testing for environmental allergens is not as worrisome to me as food allergens. A lot of people could have a pollen allergy, for example, and also have chronic spontaneous urticaria. And the pollen could cause hives here and there. But if they're having hives more frequently and it does not coincide with exposure to the tree pollen, then they might have two diagnoses, CSU and also pollen-induced hives when they're exposed to pollen. So the diagnosis of environmental allergies may just be helpful for the person just to navigate life and understand when they need to shut the windows, how often they need to wash their sheets, things like that. But it's not as worrisome to me as overdiagnosing food allergies.
Okay, super. So it really sounds to me like history plays a large role in your whole diagnosis process. And with that, are there any other tests you would consider doing with a patient who you consider might have CSU?
So in patients with chronic urticaria or urticaria that's been present for over 6 weeks, we don't want to do too many screening tests. And right now, the recommendation is just to do a CBC with a differential, which is a complete blood count with a differential, and something called an ESR or CRP. So starting with the CBC or the complete blood count with differential, what that means is that this is a test that looks at the red blood cells, white blood cells, and platelets in the blood, including the different types of white blood cells like the neutrophils, lymphocytes, monocytes, basophils, eosinophils, which is what the differential means. And so that's just a way for a doctor to look and make sure that things look okay in your blood. And then the CRP and ESR, those are both two separate tests that essentially look for overall inflammation in the body. If they're elevated, that means that there's signs that there is inflammation in your body. And that's when, if any of these things are abnormal, we might order more testing to see what could be causing the inflammation, because chronic spontaneous urticaria on its own should not cause inflammation in your body and should not change anything in your blood counts.
Okay, so these 3 tests that you just mentioned are really helping you determine whether it is really spontaneous or if there is something else going on in the body. And then if there is something else going in the body, you would dig deeper in that direction.
Exactly. And I also want to use this as an opportunity for all my patients. When they come in, I usually ask them if they're up to date with all of their other health issues. I always want to make sure that the patient has had a general healthcare maintenance exam. So that means that they've had whatever testing and procedures that they need to get done as guided by their age and gender. So for example, at my age, I should have a colonoscopy done and a mammogram done. And so I would want to make sure that if someone came in, they were my age, that they have had those things done so that we're not missing any other diagnoses that could be happening and that we need to worry about at this point in someone's life. And so having a basic checkup and making sure everything's good to go is super important.
What I'm hearing you say, Dr. G, about getting a full physical and making sure that all your T's are crossed, all your I's are dotted. So as a patient, you know that everything has been checked, and then you can confidently say that there's nothing else going on in the system at this point that could be causing the hives. So it is truly spontaneous urticaria.
Exactly. And it's really just lots of history taking, making sure that we've really done what's necessary and not overdoing it. And that, I think, is the main thing that most doctors will agree on, is that we never want to over-test, because it can just lead to this kind of cycle of, oh, now this looks a little bit off, so now we need to do another test. Now we need to do another test. And it just leads to a domino effect. So that's why it's just very, very important that we logically think through things. And that's also why there's guidelines on what tests need to be done at what age. Because if we test too early or we test too late, that's when we get into problems. So it's really using the guideline-based testing and then also using the history to guide our testing. That's just in general important for any diagnosis that we're making. And in chronic spontaneous urticaria, this is just a clear example of where, again, over-testing can be harmful, and then under-testing can also be harmful if we don't get the clear history.
Dr. G, do you know, because you talked about this fine balance of testing, but it sounds to me like this fine balance of testing could take a lot of time. Is the process to diagnosing CSU, does it take a lot of time?
To be honest, it doesn't. When you see a specialist that's familiar with chronic spontaneous urticaria and you have a history that's clearly indicating that you have chronic spontaneous urticaria, we do the preliminary testing that we need to do and everything looks good, then the diagnosis can be made fairly quickly and we get you started on treatment that first day. And so it's really just going to a physician that's familiar with hives, with the different reasons that a patient can present with hives. And I don't think that the diagnosis needs to be that difficult, because it's not a difficult diagnosis to make. It's just difficult to make sure that we're not over-testing and under-testing, I guess, is the main thing, and just making sure that the patient gets the treatment that they need.
Despite how complicated this episode might have sounded, you've left us with a little piece of confidence and hope that it's a lot, what we discussed, but if you really go see a specialist who knows about hives, it doesn't have to feel like a daunting journey, because if they are a hive specialist, they kind of already know where they're going, how to navigate it. So my biggest takeaway from what you said in all of this, Dr. G, is go see a specialist who knows about hives. That'll make your journey to diagnosis so much smoother, and it won't have to take longer than necessary, and you won't have to get tested more than necessary.
As usual, that was a great summary, Kortney. And next episode, we're going to be talking about treatment options for chronic spontaneous urticaria.